Good morning, good afternoon, good evening, everyone. Give me a thumbs up if you can hear me. Hopefully, people on their computer can hear me okay. I'm Jen Johnson, past president of the IVAPM, and I am excited this afternoon to have Dr. Tasha McNerney here. Quick introduction for those of you who don't know who Tasha is. She is a veterinary educator, certified veterinary technician, my home girl from Philadelphia, so we have a lot in common there. She's a veterinary technician specialist in anesthesia and is the best about educating all of us about pain management and analgesia, anesthesia. She's one of the founding members of Veterinary Anesthesia Nerds, and I'm sure you've seen her talk before, but if you haven't, you're in for a treat. I'm going to mute myself and give it over to Tasha and let her talk about cats today. Thanks, Tasha.
Thanks. Hi, guys. As you can see, I have my own cat who's very interested in this lecture. Apologies. Hopefully she won't be too much of a distraction. If not, I may have to lock her away. Hi. Thank you so much for joining me. Thank you also so much to the IVAPM for giving me the opportunity to talk about A, pain management, which I love, but also B, to talk about it with felines. Absolutely love pain management, absolutely love dealing with cats. Did take me a little bit. I would say that I didn't start out as a super, like when in veterinary medicine, I originally was like, I'm gonna do wildlife. And then I spent 1.5 years at a bird center and I was like, I'm not gonna do this anymore. These birds wanna kill me. So then of course I just went to cats because they are, very similar in personality. So I want to tell you guys that I work clinically, mostly in anesthesia. I am a VTS in anesthesia, in addition to being a certified veterinary pain practitioner. And most of the time clinically, when I'm dealing with felines, I'm dealing with them in the context of anesthesia. So today we're going to talk about pain management, and it's going to have more of an acute pain management slant to it. We certainly are going to touch on some chronic pain management and some things in chronic pain management, but really for the most part, today we're going to talk about acute pain management, surgical pain management, ways to recognize it, ways to treat it, some things that maybe we'd be missing, and really how to tackle this from a team approach. My big thing is always how are the veterinarians together with the technicians and nurses and the clients and owners really working together to create the best pain management protocol. So if along the way there's any questions, pop them into the chat. Myself or Dr. Jen Johnson will see them, bring them up. Either we can stop if there's something pressing, or if you want to wait till the end. Again, either way is fine with me. I want you guys to feel like you're getting some good information, but then also give you some resources where you can dive in and do a little more research on your end and just learn more about how we manage feline pain. All right, let me see if I can. Okay, here we go. You guys already heard all this, so you don't need to know. But yes, I live right outside of Philadelphia. I work as a relief technician for all the places around here in anesthesia. Basically, any practice that needs anesthesia help, I will come in and help you. If your staff needs to learn about, how to use a ventilator, I'll come in and help you. I absolutely love everything anesthesia, physiology, all that stuff. Side note, I am a Spartan, so go green. That's me taking my son to the campus and trying to convince him that, he needs to be a Spartan as well. We're not all the way there yet. For some reason, he's still a Philly kid. So he's thinking like, I'm going to go to Temple. And I'm like, listen, you're a Spartan in there. I also love cats. I'm deathly afraid of horses, and we recently adopted a Chihuahua. So that's a little bit about me and kind of like where I'm at. So let's talk about feline pain. First of all, I think that we want to make sure that all of your staff, whether it be receptionists who are initially talking to the clients on the phone, to our technicians, especially some of our newer grad technicians and assistants, and also all of our veterinarians, we want to make sure that we can recognize feline pain and that we are asking the clients the right questions. So what are some communication questions that we can be asking these clients regarding pain before surgery, but maybe during that physical exam before surgery. What are some clues to possible pain that may be going on before surgery is even started if they're in for surgery? And then within the context of surgery and specifically recovery, if you're a recovery technician or you're an assistant that's put in charge of monitoring that patient during recovery, or again, you're a client or owner looking to monitor your patient during that recovery period, what are some physical clues that we're going to be looking for that are going to alert us that this patient might be in pain? And how can we communicate those findings to the clinicians and work together as a team, again, to create the best pain management protocol specifically for this patient? So I think that that's another theme that you're going to see, guys, as we kind of move through in anesthesia. When I first started, I'll say that when I first started in anesthesia, and I'll say I've been in this for a while now. I got my first veterinary job in 2003. So I've been in it for a little bit. And when we first started, we really thought about anesthesia, pain management, and post-operative pain management and recovery in very different ways, right? You guys have probably all heard that we wanted these patients to stay quiet, or it's okay if they're in a little bit of pain because then they won't move around as much and then they won't pop their stitches open. And these are the kind of the ideas that we were told back in the day. And we kind of now know that that's actually not what we want to do. We want to get that pain control in as soon as possible. We want to be monitoring them continuously, and we want to change or adapt our pain management protocol based on the pain scoring in that individual patient. Because as you guys know, and as you guys have probably seen, and especially if you've ever dealt with huskies, you know that certain breeds, certain animals are going to deal differently with pain, right? So when it comes to cats, again, cats are usually going to hide their pain, but what we really want as far as the technician communicating together between the client and the clinician, we want to listen to what the owner has to say. So this is whether I am on the phone with the owner and getting maybe a history before they come in for an urgent visit, or if they are about to come in for a surgical procedure such as dentistry or a spay or lumpectomy or anything like that. I'm going to be watching the pet, right? But I'm also going to be talking with the owner. What is their description of the day-to-day activities? And some of those things that they say might clue you in as to whether or not this patient could be experiencing some type of pain. Certainly, if we see overt things like the owner tried to pick them up and now this cat is growling, or there's vocalizations, if we see some things such as reduced activity or interaction, if, normally the cat would sit with them during, TV time or dinner time, and now the cat is hiding under the sofa or doesn't come out as much. These are things that we want to know about and we're going to talk to the owners about. If we're noticing decreased grooming, certainly a decrease in appetite. If they are starting to intentionally wound themselves or self-mutilate, you see this a lot with hyperalgesia and neuropathic pain states. So if you're seeing things like this, or your owners, every once in a while, if they mention like, oh yeah, I tried to pick him up and she swatted at me, or she used to jump up onto the counter to get her food and now she's not as interested. These are some things that I clue into, and I want to ask more questions about that. Now, again, I said that we were going to talk about more from an acute pain standpoint as we get further into this, but just a note about for chronic pain, and especially feline chronic pain. We know that chronic pain doesn't always just mean osteoarthritis. I think that because we have a lot of marketing materials and a lot of pharmacology now to look at osteoarthritis, but it's not always osteoarthritis. Chronic pain and the chronic pain states, maladaptive pain, neuropathic pain, all of this kind of thing can be associated with osteoarthritis, but we can see this sometimes with chronic dermatitis or otitis. If you guys have ever seen animals that get hyperalgesic and then start to have wind-up pain and chronic pain states from ear infections, right? Certainly we can see this sometimes in neuropathic pain states. So it's not always just osteoarthritis. Certainly that can happen with chronic pain, but that is not the only way that we get chronic pain in feline patients. So again, there are some different things that we need to take into account, and maybe some even different questions that we might ask if we are dealing with chronic pain. Now, when I talked really quickly about pain scoring systems or pain scales, this is one that I think is very valuable for you guys. If you want to take a quick picture of this, this is going to take you to the Feline Musculoskeletal Pain Index. This is a clinical metrology instrument. This is going to be a scale or a tool. This is going to be scoring pain associated with chronic musculoskeletal disease. So again, this is not the same as the feline grimace scale, which we'll talk about in a second when we're talking about acute pain. If you have a client that is, you're talking with them and you think that this feline is experiencing more of a chronic pain state, changes in jumping up onto the counter, changes in food, changes in moving around, again, hiding, etc. Maybe you want to have the client answer some questions as far as this pain scaling goes, because we're going to treat chronic pain a little differently than we treat acute pain, right? Now, again, there is a lot of reason that we could develop chronic pain. The most common sign is the most common cause is osteoarthritis. However, that is not the only cause. Remember, there are all kinds of things that can lead to chronic pain, maladaptive pain, hyperalgesia, etc. But we do see it a lot. And it's not only in dogs. We know that cats are experiencing osteoarthritis pain. We see this. There are a lot of tools that you guys can use. And again, if we are not treating that pain, and we know that felines do experience osteoarthritis pain and musculoskeletal disorders, if we're not treating that pain, that chronic pain can lead to these, worse conditions: central sensitization, hyperalgesia. This is where, those increased action potentials are just ready to go. And now you guys may have seen this before, again, when we see behavioral changes in our patients, when that chronic pain becomes maladaptive, and now we're getting changes in our neuroplasticity. And when our patients become wound up or hyperalgesic, then it becomes more difficult to treat their pain, right? We're a little bit behind the 8 ball. That's not to say that it's impossible. There are a lot of ways that we can do it, and we'll get into that. But certainly, if we see a patient that is experiencing some sort of chronic pain component, we want to get a pain control plan in place as soon as possible, so it doesn't lead to worsening maladaptive pain, hyperalgesia, etc. Now, this is something that I think is really interesting, because on the human side, we actually have a lot of studies to show that there is an emotional component to chronic pain. If anybody listening in has ever experienced chronic pain, I myself have, interestingly enough, we're going to talk about multimodal. Before I got on with you guys, I did a little TENS unit session because I have chronic pain in my neck. But people, we have found, at least there was a 2022 study in the American Psychiatric Association, that 35 to 45% of people who experience chronic pain also experience depression and worsening depression as the pain gets worse or is untreated. And you guys probably have, that if you have a day that you have a really bad pain day, your fuse is shorter, you don't want to deal with a bunch of things, right? Emotionally, it's not a great day for you. And our pets are no different. So certainly, if a pet or a cat is in chronic pain and we start to see some emotional changes or personality changes, right? Because we don't have the data to say that, yes, this cat is identifying as depressed right now. But we know that these personality changes do happen. So if we're seeing this, we're talking with the owner about it, that's going to tip us off that maybe there's some chronic untreated pain going on. We want to know this. So changes in behavior are a really strong indicator for a feline that's experiencing chronic pain. Certainly, they get more territorial. They decrease their hunting behaviors. So they increase their marking behaviors as well. They're less active at dawn and dusk, which again is usually the more active time for our felines. If you feed them up on an elevated surface or a countertop or a tabletop or something like that, and they stop getting up onto surfaces, that's a big red flag there as well. I think that most of the time we just don't have a lot of time, right? As clinicians, we're really busy. We're trying to fit everything into this 20-minute appointment. If you can, empower your CSRs and empower your technicians to do these check-ins, especially from a pain management standpoint. if you guys at your clinic are doing pain management consults and you have cats that are maybe, have just started on a non-steroidal anti-inflammatory, you want to make sure that someone is calling back and checking in with that client, right? Client communication is going to be a really, really big thing. And we need to make sure that we are paying attention to what our clients say, right? Because sometimes they will just attribute, they're slowing down or stiffening up, like, oh, well, they're just old. That's just what happens. Or, yeah, she's gotten crankier. My cat has gotten crankier and more likely to bite you if you touch her, but that's just because she's cranky and old. No, if you have a cat that went from, pretty much being a nice cat to now years later, you go to pick her up and she swats at you, or there's hissing, or you just touch her back end and give her a little scratch and she turns around and hisses, and that's what didn't happen months before. We really need to dig deeper with that client. So there's a lot of tools out there. Again, for us there's questionnaires that we can give to our clients to kind of tap into what's happening, and then to kind of reframe and to get our clients to see that just because these things are happening, it doesn't necessarily, it's not just because they're old. Usually it's happening because these cats may have some kind of injury or illness that is leading to chronic pain that we need to know about. So if a cat has all of a sudden started bad behavior, like urinary accidents, certainly we want to get that cat in to be seen, right? We immediately start thinking like urinary infection, but also maybe it's osteoarthritis. Maybe there is some kind of, chronic cystitis. Maybe there's some kind of chronic pain happening. So dig a little bit deeper with those owners if you have something like that. Mainly, I want to talk with my owners and ask, is the pet eating normally? Is she hiding more often? Are they taking regular walks? Which I know you're thinking, what, for a cat? But my husband has our one orange cat trained to go outside, and this cat lives for her walks on her little harness. So if for some reason Clementine has stopped wanting to go to the door and go in on her walks, then I know that there's something going on, right? Are they able to go up or down stairs? Are they using the litter box normally? Are we seeing an increase in accidents? Zoetis also has this really nice questionnaire for pet owners. So if you have a feline pet owner that you would like them to fill out this questionnaire maybe before they come in for their pain management, especially if this is a senior physical exam. You have a senior physical exam coming up on a cat, I usually will ask these owners, hey, can you fill this out beforehand before you come in? That gives us a really good starting point as to, some things that we can bring up, or if there are any issues that need to be addressed from, again, a senior feline standpoint. So let's jump into analgesia for a second. And why do we need analgesics, right? Why can't we just let animals be in a little bit of pain and then they won't move around as much and they won't hurt their incision sites and they won't, hurt their joints as much, and this is okay, right? We do know that there's different types of pain, okay? And pain receptors or nociceptors, let's just talk about those for a second. This is the free endings of our sensory neurons. Now, if you guys are on IVAPM, you guys know that we love the word multimodal, right? We love the word multimodal. If I had $1 for every time I said multimodal, I would be on a yacht in the Caribbean, probably. But the pain pathway starts at these nociceptors, right? So that's going to start the pain pathway. And that pain pathway is going to go all the way from the periphery up into the spinal cord and into the brain, right? Where these pain signals they're transmitted, they're modulated, and they're perceived, etc. So the brain perceives these signals and then sends impulses back down to let us know, is this sensation that's coming in a painful one, right? Should we pull our hand away from this hot stove, or is it just a pressure signal, etc. So the reason that we really, when we talk about multimodal from a pain management standpoint, is that as there are different pain pathways coming in, right? If there are different pain pathways and different pain processes, some drugs are going to work specifically on some pain processes, right? So if we have something like transmission of those signals, right, we know that our local anesthetics are going to work on transmission. Then we know that drugs like opioids or our SSRIs or gabapentin or something like that is going to work on modulation of those pain signals going through. And then how our brain perceives those signals is affected by other classes of drugs, again, like opioids or alpha-2 antagonists, things like that. So please note that if you are creating a pain management protocol, we want to make sure that this is not just, you know, one drug. We would never give an animal, you know, just like, here's your dose of methadone and you're on your way. That's why when we look at things from, you know, when we're building an anesthetic analgesic protocol, or if I'm doing a chronic pain consult with a client, we are usually doing like 2 or more drug classes combined with non-pharmacological or physical therapy modalities to get the truest multimodal approach to all of these things. So multimodal. Multimodal, again, doesn't have to only mean pharmacology. Things like how the cat is intaked into your facility makes a big difference as well. So let's say that we are doing a dentistry on this cat or a surgical procedure. We are going to do the lowest stress possible feline intake on this cat. So if I have a cat coming in, I'm not allowing them to wait in the waiting room. I'm trying to get them in as soon as possible, right into a quiet room. We're going to do a separation between dogs and cats. If you guys have the ability at your practice to have a cat only room, so that way there are not dog smells in this room, that's going to be better for your feline friends. So if you can, that's a nice way to go. Also, towels that have been sprayed with Feel Away or some pheromone spray placed over the carrier to minimize any stress. And we want to make sure that, again, our CSRs or whoever's doing that intake doesn't immediately, or nobody puts the cat down on the floor. Cats don't want to be down on the floor when they're in their carrier. When they come in to us in the practice, we're going to take them and put them, you know, with the Feel Away towel and then right onto the table in the exam room, not on the floor. Again, all of these little things are going to make a difference when it comes to that stress and anxiety that's building in cats, because let's face it, most cats do not enjoy being put into a carrier, driven across town and into your veterinary clinic, right? Every once in a while, you might get one that's like nice and chill with it. But for the most part, they come in, they are very stressed. So a lot of times we have clinicians that will use gabapentin beforehand to treat that feline stress. We use gabapentin quite a bit in our hospital. The anesthesiologist that I work with, we utilize gabapentin a lot for in-hospitalized cases, maybe cats that need to be in on IV fluids in our ICU, or preemptively before an anesthetic procedure. Again, I am not using this from an analgesic standpoint. I am using this to treat the feline stress. So we're using this as an anxiolytic. So we're making sure that we're giving this gabapentin. Again, I'm not talking from an analgesic standpoint. We could talk about that in a second, especially in the context of gabapentin in acute pain. Maybe it doesn't do what we thought it was doing, but truly gabapentin, using it to de-stress our feline patients does make a difference. We do like this. Now, let's say you have a cat come into your clinic and you need to do an ultrasound on them, or you need to do some diagnostics, but you cannot get a pill or even an injection to this cat. So if you guys have been paying attention on anesthesia nerds, you know that we are not proponents of doing things like, you know, boxing or masking down cats anymore. Instead, what you can do is combinations of drugs, and a lot of the drugs that we use in anesthesia and pain management are very well absorbed orotransmucosally. So we do things like, we have a cat, this video that I'm going to show you guys was a cat that came into our practice that needed an ultrasound, right? This one was having small accidents around the house. We wanted to get a cysto. We wanted to check this cat's bladder. We could not get near this cat. And the owner was like, I can't give the gabapentin at home. So what we ended up doing was a combination of kitty magic. This was if you can see in the syringe there that I have butorphanol, ketamine, and dexmedetomidine together in this. And then I have a catheter tip on the end of it. Let me see if I can get this video to play for you guys. Hopefully I can get it to play. There we go. So I've just used the catheter tip to squirt that into her mouth, and the catheter tip is going to help propel the drug forward a little bit. It does take a little bit of maneuvering to get yourself into position. Wait until the cat hisses at you, and then you give your drug. Again, whatever drugs you have decided to give, if you want to just do, maybe butorphanol and ketamine, if you want to do butorphanol and dexmedetomidine, we did the combination of all of them. And then this is just a video of this cat about 25 minutes afterwards. She allowed me to place a muzzle on her, and then we were able to place an IV catheter. We were able to get our ultrasound, get our cysto, and then we were able to manage her. Turns out she had some pretty bad cystitis and some inflammation. Her kidney values were not great, and she ended up, she didn't love it, but she was in the hospital with us for, I think like almost 3 days in our ICU on IV fluid to give her kidneys a little bit of help there. Oh, I don't want to play this again. Let me see if I can get past that. Sorry, guys. A lot of cat screaming for today, for where we are in the day. So again, let's talk about multimodal analgesia. So even within the combination that I gave to that cat, that was multimodal analgesia, right? Between those 3 drugs, ketamine, butorphanol, and dexmedetomidine, they're working on different parts of the pain pathway. They are working on different things, and that in itself is a multimodal analgesic cocktail for a cat. Now, I always want to make sure that I let people know when I'm talking about multimodal analgesia, I'm not talking about only pharmacological interventions. There are other things that we can do to keep our patients comfortable, minimize their stress, etc. that are going to be part of that multimodal protocol. So, but when we say multimodal, we're just saying different drug classes or different methods of doing things that are not just one. We don't want to only, rely on just giving a cat buprenorphine and that's it, or just giving a cat gabapentin and that's it. We want to make sure that we're combining therapies in order to get the best analgesic experience for this patient. Now, let's talk about pain scoring systems, because I do think that this is important. Your clinic needs to decide, you guys as a clinic need to decide what pain scoring system you want to incorporate, what is going to be the best for your clinic, whether it be something like here, the Colorado scale, the feline grimace scale, or if you want to do the Glasgow short form or the Helsinki, like whatever you guys decide as a group. I think the main thing is that you need to sit down and have a staff meeting that's dedicated to making sure that all of the people that are on staff that are responsible for evaluating pain in your patients that are in hospital are trained on these acute pain scales. So whatever acute pain scale you guys have decided at your clinic, make sure that your staff is trained on this appropriately. And that doesn't mean just sending out an email like, hey guys, we're using Colorado. You want to sit down at a staff meeting, give examples, make sure everybody understands the difference between a score of a 1 and a score of a 3. So that way you're all on the same page and there's not as many discrepancies when it comes to individual pain scoring. When we talk about acute pain, at one of the clinics that I do relief at, they use the Glasgow composite pain scale. It does take a little bit more time than maybe the Colorado scale. However, it has been validated. So that is kind of nice that we have that. If you guys want more information on the Glasgow composite pain scale, if you just Google it, you can reach this document and you can print this out and have copies of this laminated around your hospital so that everybody knows kind of what they're looking for and what the pain scoring system is. An even more exciting one is the validated feline grimace scale that came out a couple years ago. This is going to look at ear position, orbital tightening, whisker position, head position. The cool thing about this is that it is available on an app. So if you guys go to your app store on your phone right now, you can do feline grimace scale and download the app, and easily in real time, if you have everybody on your staff download this app, then it's really nice to be able to just, look at the cat in front of you, assign them these scores, right? I'm going to look at their ear position. I'm going to look at their whisker position, their eye position or orbital tightening, and assign it a score. And then I can go to my clinician and say, hey, this is what the cat scored at. I know that he's not signed up for buprenorphine for maybe another 2 hours, but he scored kind of high based on all these criteria. Here's a look at it. And can we maybe add in an additional analgesic or rethink our analgesic plan based on this? It's really easy to use. And again, once you guys get used to what you're looking for, you'll be able to walk by a cage and be like, oh, that patient is experiencing some pain. What can we do to help that patient? So the feline grimace scale, we can go anywhere from a score of 0, which means pain is absent, to 1, moderate, 2 is like obvious. Sometimes they're not possible to score. If you have a patient that is, right, you shouldn't score them while they're sleeping or they're eating, those kind of things. But if you get to a pain score of 4 out of 10, and at the end, when you say calculate the score, it'll give you a score and it'll say to you like analgesic intervention is needed. And then you can go to your clinician and discuss this. So this is what we're looking for with this feline grimace scale. And again, once you guys get used to exactly what we're looking at, you'll be able to recognize it right away. And now I'm like constantly looking at my own cats at home, right? Like, oh, is your whisker position, are you in a little bit of pain? Let me see. So with this one, again, a score of around 0, you can see that this cat, the ears are facing forward, those eyes are open and bright, the whiskers are loose, the head is kind of above the shoulder line. That's, you know, look at this tabby on the end and you can see how different. Those ears, they're flattened, they're rotated outwards. Those eyes are squinted, right? That muzzle is tense. You can see that. And that head kind of dips down below or is tilted towards the chest. So when we see things like this, then we know that that patient is probably pretty uncomfortable. So let's do it together, right? So let's see. I went into this clinic. I was teaching some dentistry local blocks to a local clinic, and I thought I'm going to score this cat just as an example because we were messing around with the feline grimace scale. So again, if you guys look at this, like look at his ear position, look at those whiskers, look at his head position, look at the eyes, right? If we were to give this guy was, yeah, he was hospitalized as a medical boarding. I think this was a hyperthyroid cat. Yep. That was in the hospital there, again, not on any medical treatment other than getting his hyperthyroid medication. And if we look at all of the things, what do you think you would score him at, right? It's probably going to be pretty low. This is not a cat that's in pain. Now, let's alternately look at this friend who came into us. This cat was dropped off by a Good Samaritan into one of the clinics that I do relief at. And he had a huge injury to his rear leg, and he ended up needing a rear leg amputation. So again, when we look at this cat in the context of acute pain, look at ears, look at the whiskers, kind of hard to see where his head is with his body. It is lowered. It's hard to see with his e-collar on. But again, the eye position, the whiskers, the ears, where his head is, he is experiencing some acute pain, definitely. Let me see if I have, okay. So sorry for the gross pictures, but you all work in veterinary medicine, so you know. So this was what the leg looked like. And I want you guys, let me go back to this really quick. I want you to look at this cat's face right here, okay? Now, when this cat in the video, this video that I'm about to show you, this was taken the next day. So this was probably 24 hours after the amputation was performed. And this cat at the time this cat had been given an epidural. It had nocita at the incision closure. It also was on buprenorphine and it was on gabapentin as well. So I want you guys to see if when the cat turns around in this video, take a look at the difference in its face based on the previous cat and now this. Look at the difference in his ears, in his eyes, in his whiskers. It's like, again, once you get used to what you're looking for, when you see a cat in pain acutely versus feeling more comfortable, it makes a huge difference. So it makes me feel pretty good from a clinical standpoint that when I go to pain score these patients, I know that maybe my analgesic protocol is working. Now, I don't know how many of you guys noticed that I said for that cat, we did an epidural. We also did nocita, which is a long-lasting liposomal encapsulated bupivacaine. So for me, when I talk about a multimodal protocol, especially within the context of surgery or dentistry, my multimodal protocol will always, always, always include a local block, because local blocks are one of the only drug classes that we have that is going to completely stop the transmission of those painful signals, right? So they're going to stop those signals from getting transmitted. If you guys have ever had surgery or if you've ever had dentistry, you know those local blocks are clutch. We need those. So your protocol should always include a local block if you're about to do something painful. This is a really helpful thing as well via the IVAPM. So they have this canine quick dosage sheet. They also have a feline version as well. So if you go to the IVAPM website and for some reason in my head, this is not so much for cats, this is a dog thing, but I can never remember the dose of acetaminophen with codeine for dogs. So I always have to refer back to this canine quick dosage sheet. The feline one is also very nice because not only does it give you common oral pain medications, but it also gives you feline infusion medication. So if you wanted to start a ketamine CRI for a cat, etc., you could do that. They're also the IVAPM calculator that's available on the website and on the mobile version. You can do like a quick ketamine CRI calculator if you're interested. I utilize a lot of ketamine CRIs for my felines, especially felines, again, as long as they're not an HCM feline, but felines who are undergoing dentistry, we're using a lot of ketamine in those patients. Mu opioid agonist, let's see how, think about it. You guys don't have to answer this question. This is just for everybody to think about. Which of the following opioids is your clinic most commonly used for acute pain, right? And if a cat comes in and they are acutely painful, which opioid are we using? Are we using hydro? Maybe you're using methadone. Maybe you guys don't have pure mu opioids, so you're using something like a partial, like buprenorphine, or you don't have access to any of those and you're using something like butorphanol. So whatever you're using, again, remember what receptors it's acting on and what pain pathway it's acting on, because that is going to be really important. Also, the type of pain we're trying to treat is important as well. Are we treating pain that is more somatic, or are we treating pain that is more visceral? Are we treating pain that is more neuropathic? That is going to influence which analgesic choices you make and which analgesic adjuncts you have as well. So again, what if you don't have a pure mu opioid? Well, I recently did a podcast on anesthesia nerds, talking with our anesthesiologist about buprenorphine and how even though buprenorphine has a slower onset and it takes a little bit to get up into peak plasma levels in the system, buprenorphine, depending on the dosing, still a really, really good analgesic. And when we talk about buprenorphine, we're talking about cats. Buprenorphine is really amazing because we have so much versatility when it comes to the route of administration. Certainly being able to give the buprenorphine oral transmucosally, or if you are utilizing something like now they have the buprenorphine that does it's transdermal, the Zorbium. There are all kinds of ways that you can utilize buprenorphine as a really nice part of an analgesic plan. So when I say analgesic plan, again, a multimodal analgesic plan, this is usually what I'm talking about, something like this. If we had a cat that was like the previous one and in for a rear leg amputation, here's something that we would do. We would give gabapentin at home. We would do low stress handling, again, trying to keep the stress to a minimum, because we know that once those stress catecholamines get going, it's going to be harder for our other drugs to bring them down. And I don't want to have to use huge amounts of my other drugs, because then with those huge amounts of drugs, if I have to wallop them with a big dose of drug, I know that big side effects can come along with it. So we might do gabapentin to minimize stress, low stress handling. We might do something like a fentanyl and ketamine CRI. We might do femoral and sciatic nerve blocks or an epidural, NoCEDA. If I don't have NoCEDA at my clinic, then I might be doing something like plain old bupivacaine, right? If we are talking about after surgery, then we might do non-steroidals based on kidney and liver function. We might do gabapentin, oral transmucosal buprenorphine, and again, other things that don't involve drugs like cryotherapy, like laser therapy, all of those things. Again, so it's not just drugs. I got a question really quick from Gwen. That's, what is the latest recommendation on route for buprenorphine? Is sub-Q still considered less effective? So there was a study that said, again, when we were looking at just regular concentration buprenorphine, the 0.3 mg per mil, that IV or IM was considered more efficacious than oral transmucosal or subcutaneous. However, if you are utilizing something like Zorbium, which is the transdermal version of the drug, or if you're utilizing something like Simbadol, which is the higher concentration and made to be given subcutaneously, then again, it just depends on which formulation of buprenorphine you are utilizing. So if you're utilizing the Simbadol that is made to be given sub-Q, you can give the regular buprenorphine sub-Q. It's just that the amount that you would need to give sub-Q in order to make it be the same as the high concentration, usually we're not going to do that. So if you have regular buprenorphine 0.3 mg per mil, the best way to get it into them to have the most efficacy is IV, followed by IM, followed by sub-Q oral transmucosal. And those two, the reason I don't say one over the other is a lot of it is technique, right? Is the drug actually getting absorbed the way that it should, oral transmucosally? Is the drug getting swallowed, right? We don't exactly know with that. So hopefully that answers your question. There's a lot of ways that we can give buprenorphine, again, especially now with things like Simbadol and things like Zorbium, where we have more options for cats than before. Also, if you have a cat that's staying with you in hospital, realize that these patient comfort measures are going to go a long way. Here you can see one of the cats that has been given just a cardboard box with a hole cut in it, so a place to hide. We want to make sure that whatever bedding that they're on, it's able to wick away moisture, that they have a urinary catheter if appropriate. That we have been giving them a quiet room, right? We don't want to take a cat like this that may need to be in the hospital with us and put them in the cage or crate or whatever above a barking dog. Or if they have to be in the same room as the barking dog, we are making sure that we are treating that barking dog, right? One of the things that I think is frustrating from like a technician standpoint is when we're not treating the fear, stress, and anxiety of patients and they are just barking incessantly. Well, if you have a treatment area that's open and these cats can hear this, or if you have other species like rabbits and guinea pigs and other things, that's really stressful on those patients. So we want to be separating them whenever we can and then minimizing that noise, trying to keep it as quiet as possible. If you have the luxury of having a cat-only recovery area or a cat-only ward, even better. That's gonna make a big difference. So let's do a case example, you guys. This is my friend Rugby. So Rugby came into us and Rugby was a urethral obstruction. This was his second offense. And so the surgeon had discussed with Rugby's owner doing a perianal urethrostomy. So when Rugby came in, he was administered methadone. So this, I want you guys to look at Rugby's face. This was him, this was like when I came in, he had been admitted overnight. And I'm pretty sure that he got methadone when he first got admitted, and then he had gotten methadone right before I came in. So this is right before surgery. I was going to do the anesthesia for his surgery and make a pain management plan for him for his PU surgery and then into recovery. So for Rugby, we did a sacrococcygeal block. Remember, I'm always trying to utilize local anesthesia as part of my multimodal plan whenever I can. He did really great through the surgery. We transitioned him to oral transmucosal buprenorphine. We did 30 mics per kg, and his anesthesia plan, like during surgery or before surgery, also included Dexmed, Serenia. He got propofol. He had Nocita as well along the incision site, which is off-label. But again, anything I can do to help with additional analgesia, especially long-lasting. This was him 2 days, 48 hours. Sorry, it says 24. This was not 24 hours. This was 48 hours post. Now, look at the difference. Let's go back really quick. Look at the difference in this couple of days between the face here. Look at those ears, eyes, whiskers, head position. And then look at the difference here. So again, once you guys get starting with feeling grimace scoring and using that app on your phone, you'll be able to see, is my pain management plan doing what I want it to be doing? And if not, let's score it. And then I can go to my clinician and say, hey, listen, I know that this animal is not signed, this cat's not signed up for, buprenorphine for another couple hours, but here's what we're seeing when I do an FGS score on him. And what about adding in something else? Or, what about doing some other treatment modality? What's the reason here for this pain? Now, what about treating chronic pain? So certainly we don't have as much, there is more research on acute pain as far as certain drug classes. But again, multimodal is key with chronic pain. Anytime we want to treat pain, we want to make sure that we are treating it multimodally. And we're going to use some of the same treatment modalities, however, not always the same. So if we have a patient that we have determined they're going to be a chronic pain patient, we usually aren't treating chronic pain with opioids in the same way that we're treating acute pain with opioids. When we talk about chronic pain, really our big drug class or our heavy hitters there become non-steroidal anti-inflammatory drugs. Then we talk about NMDA receptor antagonists. Then we talk about gabapentinoids, pregabalin, things like that, monoclonal antibodies, which are super hot right now, and I think a really fascinating drug class. And then also supplements, DHA, CBD, things like that, and physical therapy modalities cannot be understated. These are really important. So not just pharmacology, but other non-pharma things we can do as well to help keep these cats comfortable if they're in chronic pain. Now, looking from an osteoarthritis standpoint, one of the really cool things for cats has been the development and use of Solensia, which is an anti-nerve growth factor. So this is a really powerful mediator of osteoarthritis pain. And because they can target that monoclonal antibody, that really gives us a nice, it's not a non-steroidal anti-inflammatory. So if we worry about cats with long-term use of NSAIDs, we can use something like this, especially if we have a cat that maybe has a borderline kidney issue. These older cats, so many of them do. I can tell you that I personally have younger cats, so I don't have them on something like Solensia yet. However, some colleagues of mine have started using Solensia and said that it's just amazing. One of my friends, Carrie, she has this older cat named Tater Tot, and she says that he hasn't gone upstairs in years. And she saw him bounding up the stairs, like sent me a video of it. It was pretty amazing. So if anybody is using Solensia, I always like to hear about how it's being utilized. And so many people have said that their cats are like kittens again, moving around. So hats off, read up on Solensia. It really is a cool way to manage osteoarthritis without non-steroidal anti-inflammatories. So not to say that non-steroidal anti-inflammatories aren't very useful, because they are. Another drug class I think that gets overlooked are the NMDA receptor antagonists. So these are things like ketamine or amantadine. So sometimes we have cats that come in. This is an NMDA receptor antagonist. This is going to be useful for cats that maybe need a pain reset. So maybe they've been on a non-steroidal anti-inflammatory and it's not working anymore. And maybe that pain has crossed that threshold and we need to bring it back down. So usually we'll do a 30-day or month-long course of amantadine and see. Again, we're constantly communicating with the clients to see how is this working. Always client follow-up. That's a big thing, right? So let's say I put a cat on a 30-day course of amantadine. It doesn't mean like just call me in 30 days. I usually am trying to call back the next day. Hey, how did it go? Were you able to get this medication into your cat? Because it's great that I sent it home with you, but if you can't get it into your cat, you can't pill your cat, etc. I need to know about this. So what are some, again, other ways that we can work through this? Because if you can't get your cat to take this pill, are there other things that we can look at, right? There's always, so we always want to make sure that we are communicating as effectively as possible with the client. We want to make sure that we're setting up any rehabilitation, any therapy appointments. And another big thing, if you can, and you have the staff to do this, set a specific technician up with this patient. For instance, if I was the one that did the anesthesia and the dentistry for that patient, or if I was the one who monitored that patient in recovery, I really like to be the one that does the 24-hour and then the 7-day out follow-up for that patient. If possible, I like to be the one that does the intake during when they come back for their recheck and their suture removal, like those kind of things. Not always going to work with staff, but if you can do it, then even better, even better. All right, sorry, just reading the chat, and somebody said that they use it on their cat and it was amazing. So another comment was they were on the fence of using it for stage 2 to 3 chronic kidney disease. If you do read the insert, it lists raising the creatinine in several of the cats, and that is true. I do think that that is one of those things that you just have to look at. Risk benefit, right? Is the risk of potentially raising the creatinine a little bit worth the benefit of the patient living a better quality of life, et cetera? Again, each cat is going to be an individual. So, and as the owner, you're going to know the answer to that question better than I would, but risk benefit there, definitely. Key questions to ask owners. So if I am doing that 24-hour follow-up call, or again, I'm doing that 3 to 7 day intake with them, maybe we're doing a recheck, a bandage change, suture removal, etc. I want to ask, is this cat back to eating normally? What are the eating habits like? Are they hiding more often? Were you able to actually give the post-op analgesics? Where is your cat's resting area or bed located? Certainly for a cat that maybe has just had any kind of orthopedic issue, I don't want them to make sure, I don't want their litter box to be up a flight of stairs, or their bedding or where they usually sleep to be up a flight of stairs. And then again, what are those litter box habits looking like? Are they back to normal? These are things that we want to know. All right. I know I've given a lot of things, and I went all over from chronic pain to acute pain to drugs and different modalities. I was trying to fit a lot into this little hour that we have to talk about feline chronic pain. Closing thoughts are that the technicians or the nurses and assistants that you guys have on your staff are really, really valuable when it comes to communicating with the client. So give your technicians, give them that job to be the client, the person with the client communication and follow up. And if you can, for continuity, make it the same technician if you can with your staffing. That really helps and goes a long way. Also, make sure your staff and whoever is doing that communicating knows some key differences between signs of acute pain and chronic pain. If you guys have decided that you want to use one pain scoring system over the other, again, if you decide you want to do Glasgow, if you want to do the app on the phone with the feline grimace scale, if you want to use Colorado, make sure you have a staff meeting where you sit down with all of the people who are going to be responsible for pain scoring these patients and make sure they understand all of the nuances of each system. So that way you are all on the same page as far as a team goes, and you're not going to miss anything when it comes to scoring these patients. And remember, multimodal treatments are going to be the best way to go. So a combination of different drug classes working on different parts of the pain pathway, and also adding in some non-pharmacological treatments. So things that are going to bring down that patient's fear, anxiety, and stress level as well. Always communicating with each other as part of the team, and then again with the clients, because they're a really important part of this pain management team as well. Closing thoughts. If you guys aren't, you guys probably already are, but please, please, please be members and support the International Veterinary Academy of Pain Management. They offer a lot of resources, and hopefully we can encourage more people to become certified veterinary pain practitioners. If you guys are interested in becoming a CVPP, please check out the website. It gives you all the information there. And if you guys have any questions for me, please let me know. Put it in the chat. I'm going to hang around for a couple more moments. And if not, go forth and treat our feline friends with the best multimodal pain management protocols that we can think of. Thank you guys so much.
Thanks, Tasha. Really appreciate you so much. I think everybody's like just really motivated now, especially with cats. You're looking at the chat, everybody's saying the same thing. Really, really appreciate it.
Yeah, no problem. Thanks. Hopefully it'll encourage everybody to download the FGS app on your phone. Again, for me, I thought I knew what I was doing, and now that I feel like I'm so much more in tuned with the face and the body and everything that's going on, like now I can walk by and see a cat's whiskers and I'm like, wait a minute, what's their pain protocol like?
Absolutely. That's awesome. Appreciate you, Tasha. Thanks everybody for sticking around, and any other questions, reach out to IVAPM and we'll get your questions answered by Tasha. Thanks.
Thanks, guys.
Bye-bye.